Todd Davenport, good morning and welcome. How's it going?
Good morning. It's great. Thank you. Thanks, Mike, for having me. I really appreciate it.
Oh my gosh, I'm looking forward to speaking with you. Todd, we go way back, and we won't have to belabor this too long because it's not for fodder of educational material for other people. But I think we would have met in about 1994 or 5. Is that right?
I think you're probably correct on that, somewhere in that neighborhood, because I was doing an internship at the hospital where you were working. And you were, as I recall, you were doing some PT case management at that time.
Yep, yep.
Um,
Some
so,
clinical work and some case management. Yeah.
yeah, so I'm privileged to be with you all these years later. I mean, you still thought to reach back out to me, even though you knew me before I even knew anything about PT. So I
Yeah,
appreciate that.
that's right. And we met in a building that no longer exists, inpatient rehab building that's now been demolished.
I noticed that. I was sad to see that. But man, what a for somebody who was brand new to the field at the time, learning more about it, what a special place
Yeah,
to learn about rehab and learn about PT. I mean, it had everything. So, I mean, it's just the first floor. It had outpatient orthopedics, outpatient neurology. It had a therapy pool. I was certified
mm,
as a lifeguard at the time, so I got a chance to work in the therapy pool, which was
yeah,
fantastic.
yeah.
Second floor, inpatient rehab. Third floor was cardiac rehab, as I recall. That was
That's right.
primarily done by nursing, but
Yeah,
I poked around in there and got to know some folks in there. And then fourth floor was occupational health, work injury management, and hand therapy, if I remember.
yeah,
So
yeah, yeah.
it's a
That was
great
excellent.
place to learn.
And to give listeners some context, that's we met in Salem, Oregon, and yeah, those types of facilities in a four-story building to have all of that housed with, whatever a 20-bed inpatient rehab unit that was fully attended by physiatry at the time. Uh, the golden days of rehabilitation, 3 week, 4 week length of stays, common, etc. But we will not wax sentimental for long on that. We want to talk a lot about the future of things that we don't know, that we're understanding better, that we're able to debunk. And I wanted to particularly bring you on today to talk not only about where you've come from, give us just a little bit of a understanding of the trajectory of your career, from when you got into PT school and where you are now, and then we'll talk about this field of expertise that you have that you're studying currently.
Yeah, I'll try and keep this brief. So not trying to make your podcast into a sleep aid for your poor listeners, but I don't know if there's been much of a trajectory as there has been a meander. So
Okay.
I really sort of found physical therapy through psychology.
Mm-hmm.
Was initially how that came about, and I was a psych major. I was pretty convinced I was going to go do research in psychology. And the university that I had attended, Willamette University, did not have an internship. One of the required internships was not research, so I had to find something else to do, and that something else just happened to be going into hospital-based psychology, neuropsych, because I was very interested in cognitive neuroscience at the time. So that's where I found physical therapy because the psychologists were embedded on the second floor with our interdisciplinary rehab team. And so I got a chance to go to family meetings and team meetings, and got a chance to kind of see what the physical therapists were doing in the therapy gym just up the hallway. And it got to the point where my supervising psychologist was like, Todd, we know you're hanging out with the PTs a lot now, and we noticed this, and you just have to do enough with us to make it look credible that you're doing a psychology internship.
Yeah.
But yeah, that's how I found physical therapy. And my second major was exercise science. And so at the same time I was working my work study job, I just didn't feel like handing out towels at the fitness center. So my work study job was as a student athletic trainer. And so I was trying to kind of figure out, maybe how I could use that. Loved anatomy, loved physiology, loved applying that to try and help solve problems. And the idea of helping people in the process of solving those problems obviously was very attractive. So So physical therapy turned out to be it. I ended up being fortunate enough that you all chose me as an inpatient rehab aide when you had an opening, so I could spend a year with you just making sure this is what I wanted to do. And ended up applying for grad school. And then, we can kind of yada yada through the next 20 years. I mean, it was kind of getting started with some teaching through my orthopedic residency program at USC. Doing some research as a DPT student in a cell biology lab, and then working into human participants research, preclinical research, including over at the NIH. And then, when a job came open here at University of the Pacific in Stockton, California, I applied thinking that I would get some good experience just applying for a tenure track job, and there's just no way they would hire me, and they hired me. so here I am, starting year 19 as professor and chair, fully tenured, full professor, and leading this awesome department that I'm really proud of. So it's like I said, I don't know that it's been a trajectory. I don't know that if I look back, I would have chosen my path for anyone else, but it certainly has worked. Each step kind of led the next step. So
I like the meandering description, excellent term for that as well. And I also like to reflect on what you just said there. You found physical therapy through psychology, and I think I'm going to flip myself as the reverse. I found psychology through physical therapy.
I believe
that we talk about this notion of psychologically informed practice. And to me, I sometimes wonder to myself if I'm actually a very good physical therapist at all. I think I'm a better psychologist than I am physical therapist. If you really look at the scope of what a PT should be able to do, I know anatomy great, very well. I understand exercise science well. I have no skills whatsoever manually with my hands, can't palpate and tell you anything, can't manipulate anything whatsoever to put something back into place, never have been able to, but I understand the psychology of a human being very well and can apply it well. That's it.
Yeah, it's interesting because I do think that I've been a more effective physical therapist over time, more effective educator, more effective administrator, because of sort of that psychologically informed lens. And I think that physical therapists always have had sort of the psychologically informed practice in some way, shape, or form. And of course, my area is orthopedic physical therapy, with some training in orthopedic manual therapy, and just looking at how the very definition of a manual therapy specialty has come about to be much more holistic and including kind of the whole person. We're not so much manipulating a joint anymore. We're manipulating a nervous system. We're manipulating a relationship. And that's different than maybe we've thought about in the past.
Yeah. Using drivers and triggers in a positive context. Yeah. Yeah.
Absolutely.
Well, Todd, one of the main reasons that I wanted to get you on today, this is our 5th episode, and I only host people that are smarter than me. So I've got a long
what
list
am I doing here?
That's a large pool of people that I can draw from.
I beg to differ, but I appreciate that, but I beg to differ.
Well, I want to learn from you today because I don't pretend to fully understand, not that any of us fully do, but you better than most. And I want to start with this concept of viruses. And I want to understand more about the latent effect of viruses. And my small appreciation or big appreciation, but small understanding from viruses as I learn more about, the number of cases with multiple sclerosis that might start as Epstein-Barr. And we know some more about long COVID. Okay, I can appreciate those. And Guillain-Barré, wow, I've known that condition for 35 years, and I know that most of those are going to start off with an upper respiratory tract infection. Okay, I get that, and wow, basically 2 months ago, 3 months ago today, I was strict with Bell's palsy, and a lot of those cases are post-viral. Okay, I'm increasing my appreciation for this, but I want you to tell us a little bit more about, latent viral infections. What do we know? What are we on the verge of knowing as far as, viruses? And if you want to extend beyond that, that's fine.
Yeah, no, thanks for the question. So part of my research background for the past over 15 years has been in a condition called myalgic encephalomyelitis, that we mercifully abbreviate as ME, because it's long. Sometimes it's referred to as chronic fatigue syndrome, but chronic fatigue syndrome really has sort of fallen out of favor because it's a very non-specific set of case definition criteria.
Yeah.
Um, ME tends to select for a much more kind of coherent disease presentation that is very diverse.
Hmm.
And it's diverse in its underlying kind of pathophysiology, to the point that we think of it as an umbrella diagnosis of sort of
Okay.
interlocking multi-system issues. And these interlocking multi-system issues result in a multi-symptom cascade of disabling signs and symptoms that are unusual. And where I came to really start to appreciate this was back maybe in about 2008, when there was a lab on campus here at University of the Pacific called the Pacific Fatigue Lab. And I was a brand new faculty member, and brand new faculty members can be it can be an isolating experience. People have other things to do, and you haven't kind of ramped up with your things to do yet. So I just did a simple Google search, and I said, well, who are the people in my neighborhood? And I found this thing called the Pacific Fatigue Lab. And I thought, well, I haven't heard of that before, but I know something about fatigue based on some prior research and clinical interests and all that. So I just walked over there and knocked on the door, and Stacy Stevens, who's the founder and an exercise physiologist, brought me in and explained a little bit about what they do there. And they did cardiopulmonary exercise testing for people with this condition called ME. And she sat me down at this table in their consultation area, and I'll never forget this. And she showed me two printouts from CPETs. And they had the same, initials at the top, same age, gender, and the dates were only different by 24 hours because that's the protocol they used, is two CPETs spaced 24 hours apart. But as you look at the key measures, you looked at volume of oxygen consumed and workload, especially at submaximal levels at like the ventilatory anaerobic threshold. They were two different people, Mike. Two different people. On day one, this person looked pretty normal, maybe out of shape, but normal.
Yeah.
On day two, that value crashed. It was 30% less. And the max values did not change. So you did not see, both of them change at the same time. And so that, I like to say that's the time that broke my brain.
Yeah.
And I've been trying to figure that out ever since. And at the time, it was a novel finding. There wasn't much out there on it. We since were able to publish on it, and that's been a finding that's been replicated in labs all over the world, in different samples and different countries. And it's just one of the things that we know is that we know that there's an energy deficit associated with ME, and we were able to work out some of the key differences between people who were deconditioned, you probably could hit the gym some more, like me, and folks with ME, related to the recovery period after a CPET. So so the people with ME had prolonged recoveries and all kinds of just really unusual signs and symptoms that, as a clinician, you just hear them and you think that's just far out.
Yeah.
Brain fog after going shopping, widespread body pains, sleep disturbances, palpitation, muscle weakness,
Hmm.
profound fatigue. It's like not just fatigue, but it's, as I've talked with folks who have run marathons before they got ME, and comparing the fatigue of running a marathon to the post-exertional malaise of ME. They'll tell you that post-exertional malaise is way worse. The
Wow.
fatigue is way worse than running a marathon, which to me is
Hmm.
mind-boggling. So,
Yeah.
just to say that this is a clinical presentation that is highly sort of unusual to most clinicians to even think about.
Hmm.
Um, and so as a result, the tendency, because you just don't have a whole lot of time, and it just doesn't fit a lot of people's mental models for what fatigue should sound like. It sounds like people are making this up, and so as a result, I think a lot of folks just tend to shut people out, shut people down. Um, and so as a result, I think people with ME broadly encounter a lot of gaslighting, a lot of systemic bias, provider bias,
Hmm.
and it's really difficult to find care as a result. So that's sort of how I came to get to know ME for the first time,
Yeah.
and its hallmark of post exertional malaise.
Yeah.
Since that time, we've recognized that there are a lot of ME subtypes of different conditions.
Okay.
So we see ME show up in chronic Lyme, post treatment Lyme.
Okay.
We see ME show up in long COVID.
Hmm.
And so it seems as though there are many pathogenic pathways to ME,
Hmm.
as identified by this post-exertional malaise. Now, that's not to say that all post-treatment Lyme is ME. That's not to say that all long COVID is ME. But we also see ME being perhaps more prevalent in people with connective tissue diseases like Ehlers-Danlos.
Hmm.
We see it in forms of more severe dysautonomia,
Hmm.
postural orthostatic tachycardia syndrome. But again, not everyone with these conditions has post-exertional malaise, which
Yeah.
is characterized by this abnormal recovery to an exertion. Um, and so that it seems as though there are a lot of different gateways, maybe after an illness, as you described, or maybe after
Hmm.
an infection not related to an illness.
Okay.
So it could be that an asymptomatic infection, we've sort of a lot of people's first exposure to that concept was with COVID, where people
Hmm.
could spread SARS-CoV-2 without having symptoms
Hmm.
in either the prodromal period or of the infection, or just
Hmm.
never express any of the components of the disease.
Right.
Um, so there's that piece too, but the reason that we say that is because we know that there are other pathways into ME,
Hmm.
post-vaccination syndromes.
Hmm.
Um, also can have an ME subtype. People who have undergone severe physical and emotional distress also can have an ME subtype.
Hmm.
And so, part of that driver could be the possibility of a asymptomatic infection. So,
Hmm. Yeah. Yeah. So that the when we take a look at post-exertional malaise, now as I understand it, it really has several different physiologic markers that come along with that, right? So you're talking now, if I understand correctly, um, mitochondrial impairment, energy mobilization, uh, vascular regulation, blood flow to get to body parts that need more blood flow, etc. Help me expand that even a little bit further about the physiologic tracts of post-exertional malaise, if you will.
yeah, it's a little like shooting fish in a barrel.
Okay.
There's, as I mentioned, there's a lot of interlocking sort of pathophysiological pathways
Mm-hmm.
that result in the signs and symptoms and disability we see in post-exertional malaise. And I don't know that we have the interrelationships between these pathways well worked out.
Mm-hmm.
Um, and we don't necessarily have the temporal sequence of these pathways well
Mhm.
worked out. And I'll come back around to that. But as you mentioned, what the first characterizations of what they were calling at the time atypical polio and benign myalgic encephalomyelitis, because this was known back in the polio days, and
Mhm.
so basically your infections were either polio or it wasn't polio. So typical polio
Mhm.
or atypical polio, and so this was an atypical polio infection driving this latent disability, and some of those first characterizations were of an energy robbing disease,
Mhm.
a problem where a prior exertion reduced the ability for people to exert in the future,
Mhm.
a problem of recovery.
Mhm.
And so the energy metabolism piece is where I've spent most of my time as a physical therapist and as an exercise scientist.
Mhm.
And so we do know that there are issues related to aerobic metabolism, oxidative
Mhm.
phosphorylation, all those steps of the Krebs cycle that we learned the first semester of PT school, and then we're so
Yeah.
desperate to forget.
Yeah.
Maybe it's karma, but that's where I've spent my career, is trying to understand those steps of energy transformation and how they become
Wow.
impaired.
Mhm.
And so we see it in systemic level and also at the molecular level. And we see this, the transformation metabolism piece, not only in, people with ME, but we see it in people with long COVID,
Right.
anyone who has post-exertional malaise as a component, or
Mhm.
this is in this ME subtype, seems to have this energy transformation problem. And we
Yeah.
also see it across cell types. So we see it in skeletal muscle, we see it across the immune system.
Mhm.
And so when we think about these interlocking, mechanisms in terms of, well, what's happening with the neural pathways, and what's happening with the immune signaling. Energy metabolism tends to be important to both of those processes too. The brain, as you know, is an energy hungry structure, and if it can't transform substrate into neurotransmitter, then the whole enterprise falls apart, and that's essentially
Right.
what we see in ME. Immune cells rely heavily on mitochondrial morphology and signaling in order to engage in basic functions and cell to cell signaling. And so the
Mhm.
energy transformation piece in immune cells is really important. And it's important as a backdrop when we think about people who have a hard time clearing virus, or who have a hard time with co-infections
Mhm.
of sort of latent infections of viruses that we can detect. It's that immune functioning. It may be the result of this de-energized immune system.
Right.
And so, we think about also the problems with cardiovascular system at a systemic level. There's chronotropic incompetence, meaning that the
Mhm.
sympathetic nervous system is on when you need it, and off when you need it, I should say, and on when you don't. So
Yeah.
there's a blunted heart rate response to exercise systemically. And that's reflected also in impaired microcirculation and microclots because of potential local stasis. And so the whole system starts falling apart. It's almost as though you've got this fight, flight, or freeze system that's trying to get enough blood to these cells that are screaming out that they're hypoxic, but they're not hypoxic in as much as they're just not able to use the oxygen.
Yeah.
And so now what you have is a broad scale problem with dysautonomia and POTS and so forth. And that's before we get into some of the issues with the gut microbiome, shifts in terms of being able to absorb nutrients, and so causing digestive problems, in addition to the dysautonomia causing pooling in the gut, which is also going to reduce motility and reduce absorption. So you just it's a mess, is what it
Wow.
is, and it's obvious that, I mean, the pathophysiological pathways, when you look at them individually, it's obvious
Yeah.
why someone would be utterly miserable with this and impaired by this, and disabled by this. But when you think that they're all happening together, which they are, it just turns into a complete nightmare.
Yeah. So that makes it very clear why we still have a hard time wrapping our heads around exactly all the pathways because it is so multi-system. Because you've just simply addressed here immune system, cardiovascular system, neurologic system, because we know that a latent virus can set itself up on, myelin sheaths, etc. You've talked to us about energy regulation. You've talked to us about GI absorption. So we can explain brain fog, pain, decreased capacity to produce force, increased, fatigue as a function of attempting to produce, consume energy, mobilize energy. It's massive. It leaves almost no system untouched. You haven't talked about the integumentary system, but the reality is you've captured basically every other system of the body.
Yeah, and we could bring in integumentary and lymphatic systems too, because there's some evidence for potential intracranial lymphatic flow obstructions. But yeah, it's connective tissue impairments, connective tissue elasticity, almost like this acquired Ehlers-Danlos. It's all in there, and it's I think part of the reason we haven't teased out. We haven't been able to go into sufficient depth on any one of these is a fixed budget for research. There's just not a lot of research funding out there for this condition pre-pandemic, and I've been out there and critical of folks working on the Recover projects, and the Recover projects mainly have been epidemiological in scope, descriptive in scope, less in terms of the pathophysiology, which is where I would have liked to see a lot more resources going. Recover TLC now is trying to sort of make up for lost time and get into treatment, but we've skipped pathophysiology, so it's really hard to get into treatment if you really don't understand the underlying pathology. You're just sort of taking educated guesses and swinging for the fences at that point. Yeah. But the other thing is that we don't have very many people in the field who are putting things together. So this gets into when we think about underlying pathologies, pathophysiologies in terms of what leads and what follows. We know they're associated. We know they interlock. But if we stand upstream as far as we can get and look farther upstream, where are the branch points? I think some of the emerging genetic evidence might lead us in that direction. But we need more people who can start putting this stuff together, which is sort of where my own research has started to move in terms of creating some hypotheses about why these things happen, pathogenesis, which is some missing link, some good ideas, but nothing verified, as well as sort of what leads and what follows, so that we can finally get upstream to, from treatments that may provide symptom relief in some people to actually addressing these issues of pathophysiology and pathogenesis.
Yeah. So you talk about treatments. What's one or two things that you feel we can now, let's just say, confidently debunk that should not be done as far as treatments that are in the mainstream for people with any one of the conditions that we've talked about so far? What do you feel like you'd like listeners to understand should be debunked at this point?
Well, this is where I get very unpopular with people. And so
that's fine. I'm inviting you on to be factual and as unpopular as you want to be. It's fine.
Fair enough. So if this is cutting against people's long held moral opinions, then I'll just apologize in advance. But if we think post exertional malaise and therefore the ME subtypes of various different conditions are associated with an impairment in physiological response to exertion and recovery from exertion, then that really guides us as physical therapists, in particular rehab folks who use exertion therapeutically. If a person cannot accommodate and adapt to exertion, then we're thinking not so much in the sort of using the old language of the guide to physical therapist practice, not really thinking about a rehabilitation model in terms of using those processes that aren't working, can't work in order to build them. They don't have them. Instead, we're thinking we go into a compensation pathway.
Okay.
It's a little bit like you have someone who's had a stroke, has foot drop, maybe you're trying to work on some neuroplasticity, but you're not. It's a pretty flaccid weakness. You're not expecting a lot of return. You're not going to spend a lot of time making them do that. You'll get them an AFO. And so it's a little bit like that. So if we kind of go and we think about physical exertion, because it's what we think of as physical therapists, and we know that there's impairment in oxidative phosphorylation, not that there isn't enough substrate and that process can respond. Mitochondria can respond. It can increase in number, volume, and so forth. But they just can't, there's no capacity there. Then we're not going to exercise people. And I think that really makes people uneasy, because you may have heard that we have an obesity crisis. You may have heard that we have a crisis of cardiovascular disease and other non-communicable diseases that are frequently helped by exercise. We're trying to get people to do 10,000 steps a day and this, that, and the other, and we're trying to just load it, pick up heavy things, and I'm all for that. And I'm all for that in people who have the physiological capacity to manage that and to respond. But people with post-exertional malaise have demonstrated that they don't. Mm-hmm. So the compensation approach is pacing. Mm-hmm. And energy pacing is frequently used in various different forms. But the idea is to manage exertional level balance, activity with rest in such a way that a person can maintain their own discretion about how they use their energy. And so there's a lot to pacing, but so I guess the first thing that I would just, if I take over the world, one of the things we're going to do is we're going to put in the Oxford comma as being, that's just going to be required. But the second thing we're going to do is we're just going to make sure that the first branch point in the clinical reasoning for anyone in rehab is, does my patient have post-exertional malaise? And if so, then we're not going to exercise those folks. We're not going to exert those folks. And so then the second piece that goes along with this is we know that exertion is not just physical exertion. We know that cognitive exertion, simple computation, paying attention, even using a phone screen, for people who are severe to very severe, even a shaft of light coming in through the blinds in the bedroom is too much stimulation. Sheets against the skin, clothes, that kind of thing. So we know that neurological stimulation also can result in post-exertional malaise. And so there are neuroplasticity approaches, different types of games and so forth, that are frequently used by people to try and build neuroplasticity. And those, again, there's no evidence to suggest that those neuroplastic changes would be beneficial. And the simple fact is that people have an abnormal cognitive exertion response. So we can't necessarily think that they adapt normally to that type of exertion either. So those brain games turn out to be potentially harmful. And I just think that, again, using exertion judiciously, staying away from it in people with post-exertional malaise is just really important.
Yeah, I love this, because you're telling me now that the way toward a precision rehabilitation for these individuals, if we may back it up and call it a precision compensation for them, is being very person specific, including the individual, potentially having, and I'm putting words in your mouth now that I want you to confirm or deny, having a 24 or even a 48-hour look back as to, let's look at a menu of how you spent your energy: light, cognitive, sensory, psychologic, physical, etc. And let's see how your body responded on a look back. And then let's create a prescription that's personalized for you to compensate through, so that you can function at your best level rather than taking 2 steps backwards every single time. Is that correct?
Yeah, I think that's a good way to put it. And the precision medicine approach is, and bringing that approach in is interesting because that really describes, I think, my own practice. Um, so getting back into roots in being in psychologically informed care, trauma informed care.
Mm,
Obviously, I'm doing most of my consults by telehealth. I'm doing most of my consults through talking. Most of it is through reflection. It's through integrating information from wearables because sometimes that look back is difficult for people to do
mm,
for
mhm.
reasons of cognitive dysfunction.
Right.
Remember that journaling also is cognitive stimulation. So if you crash from
Yeah,
cognitive stimulation, you'll crash from journaling. So it's
that's
sometimes
right.
it's easier to let the Garmin remember for you
Yeah.
or let the Visible app remember for you or whatever people are using. So,
Mhm.
um, people will send me screenshots from their apps, and we'll go through them together in terms of insights from that.
Yeah.
So, those are the kinds of things that I think are great personalized medicine approaches from the perspective of again personalized compensation.
Yeah. Can these individuals eventually recover with a periodization of pacing? Periodization is the wrong term. With a long enough period of pacing, can these individuals recover? What's your experience there? Or is their best hope to be able to compensate most effectively?
Yeah, so the answer is maybe.
Mhm.
I would say from the perspective of helping people with long COVID, I've had more people do better in a shorter period of time than I have working with people who had pre-COVID ME. And
Mm,
I think that has to do with the fact that there's a lot out there for people with long COVID, building on the patient-derived knowledge and the research in ME to really sort of start to pace sooner
mm.
and do things that could be potentially beneficial to curb the trajectory of the
Yeah.
pathogenesis. Um, I think of I've been working with people for long enough that I've seen them improve, get back into to different life functions, back to work, more active in family, so forth. And I've seen folks relapse, and
Mhm.
so because of the potential for relapse, I always think of this as a chronic condition
Mhm.
and recovery is very much a fraught term.
Mhm.
I don't know what recovery really means. So
Yeah.
there are folks who would consider themselves wouldn't consider themselves recovered, even though they're doing most of their things.
Mhm.
They still have to take micro breaks. They still
Mhm.
have days that they need to take it a little easier than others. They're a lot better than they maybe were at one point.
Mhm.
But they wouldn't consider themselves. The very few people would consider themselves to be fully normal.
They're
Um,
managing a condition. Yeah.
yes, so this is a chronic conditions management type of a situation, and I'll
Yeah.
also say that very few of my clients tend to go into a structured exertion based program. Maybe
Mhm.
they'll go for a walk once in a while because they feel like they want to go out and get some air and they like the sunshine or they love the beach or whatever it happens to be. But this is not the kind of thing where we're asking people to hit the gym, that they're going back into anything that we would consider a progressive exercise program simply because their function, their daily function occurs against the backdrop of this limited ability to respond,
Yeah.
this physiological inability to respond.
You know what? I mean, this is going to sound like a complete unrelated tangent, but I'm just going to reflect momentarily on what we've talked about here. We understand that a lot of times, especially in Western medicine, we're enamored with imaging and we're looking for bases that can be found in an image that we can see or someone can read. And we understand in these conditions that to some degree they can be invisible. Yet what you're telling us here is that you're at least giving people the ability to know the multi-directional and multifactorial nature of their conditions so that they can learn how to manage an invisible condition by, what news channel are you going to listen to? What are you going to consume? How are you going to spend the energy you do have? Who are you going to be surrounding yourself with? What are you going to expose yourself to immunologically, and so that they can best manage an invisible condition by understanding the different parameters that may afflict them, exacerbate a condition, etc. Am I hearing that correctly?
Absolutely. Absolutely. And
Yeah.
I think this is the key piece that informs the future of what we might have at one point have called rehabilitation
Yeah.
for these conditions, but isn't necessarily rehabilitation. I find
Right.
myself to be more of an educator and a health coach.
And that's the thing, is that just like we can become enamored with imaging, we can also become enamored with, well, I must not be helping someone if they're not habilitating or rehabilitating. But actually, an informed opportunity to help them manage a condition is skilled care.
Yeah, absolutely.
Yeah.
I think our fields, the rehab fields, selects for people who are very compassionate,
Mm-hmm.
and we select for people who want to identify and fix problems.
Yeah.
And I think we run into a kind of our own psychological block when the problem is not fixable. We think that maybe we're not doing what we should or could be doing, or there's no role for us. When I think there's always a role for someone who's knowledgeable, who's compassionate, and who is willing to sit with someone in their time of need.
Yeah, that's excellent. All right, now I want to pivot just a little bit related, just so that both for my own edification as well as listeners can understand a few terms that can be a little bit confusing because there's a degree of Venn diagram overlap here. So when we talk about the pathways of post-exertional malaise, one of the things that we've talked about is an overlap with a dysfunction in the autonomic nervous system. However, the term dysautonomia is not the same as post-exertional malaise. I'm starting to become more understanding of that. You, as an individual that operates in these spaces, help me just to educate the rest of our listeners here. Help us define dysautonomia. Tell us about how it overlaps with PEM, and tell us how it differentiates. You've done a great job already defining PEM, but just help us dissect those two out a little bit.
Yeah, sure. So dysautonomia is as you mentioned, broadly defined as a dysfunction in the sympathetic autonomic nervous system, fight, flight, or freeze.
Mhm.
And you know, everyone with post-exertional malaise has some kind of dysfunction in the sympathetic autonomic nervous system. So when we think about the Venn diagram, PEM is in the middle of dysautonomia. Now, we can't explain all of PEM through dysautonomia. So if we
Right.
think about our Venn diagram, we're cheating a little bit because we think about writing the Venn diagram on a two-dimensional sheet of paper or a two-dimensional whiteboard. So we're playing 5D chess
Yeah.
here.
Yeah.
But we can say that everyone with post-exertional malaise has dysautonomia, but not everyone with dysautonomia has PEM. And we can't use dysautonomia to explain PEM.
Mhm.
How we know everyone with PEM has dysautonomia is they either have chronotropic incompetence, which is a blunting of heart rate rise with workload. Normally, you expect those to be linearly related. So as you start working
Mhm.
harder, your heart rate's going to go up in order to pump blood more efficiently and faster. But that tends to tail off in people with post-exertional malaise. In addition, we know that some people with post-exertional malaise will meet criteria will also have abnormal heart rate with position changes. So sitting to standing, prolonged standing. And some of those folks that have more orthostatic impairment will meet clinical criteria for postural orthostatic tachycardia syndrome, which is how some people come to access the healthcare system through the heart rate and the fatigue issues and some of the digestive problems and the cognitive issues that people with POTS will have.
Yeah.
But on further investigation, you note that the POTS tends to sort of come and go, worsen, has times of worsening, wax and wane, I guess I should say, times of worsening and improvement. And that tends to be dependent on prior exertion. So you start chasing down this whole idea that this dysautonomia or POTS may be associated with post-exertional malaise. Mm-hmm. So that's one example. Yeah. The viral persistence literature is fascinating. The immune dysfunction literature is fascinating. And yet there seem to be in that subgroups of people with more or less viral persistence or signs of suggesting viral persistence of different viruses, different latent infections that a person hasn't been ill with this condition, this disease for years, but they're showing signs that their immune system's activated against it. But it's not everybody. Again, a lot of the GI or the GI manifestations are sort of subgrouped, which kind of gets at this idea that post-exertional malaise, I think, if we think about the Venn diagram of all of these different types of conditions, tends to lay over the top of all of them, not be any specific one, but lay over the top of all of them. Mm-hmm. And I think the only real distinct feature of post-exertional malaise gets back to the first formal characterizations, back in the 50s in the UK, which is as an energy robbing condition.
Yeah. Yeah, that's excellent. It helps. And I'll admit, I don't have perfect clarity on all of this still. So I'm going to try to summarize a few things back before we wrap up. So we could have an individual with Parkinson's disease, and we know some of the phenotypes of Parkinson's disease have more autonomic involvement than others. But we know that one of the main subtypes does involve a degree of chronotropic incompetence, as you expressed, and we could have an individual with PD, with dysautonomia, that doesn't have post-exertional malaise. We could have an individual with POTS that has post-exertional malaise, and we expect them, because of everything that defines POTS, we know that by definition they have dysautonomia, and many of them will have post-exertional malaise as well. So we know that those are two different clinical pictures to kind of put some hard signs to that as well, or to put a clinical face to it where the diagrams sometimes do and don't overlap. Any reflections on that? Is that accurate?
No, I think you've done a nice job of summarizing. And I teach medical conditions and diagnosis in our program, and so there's sort of two ways to think about diagnosis. Obviously, there's Occam's razor, which is the most concise arguments, probably the best one, and then the flip side to Occam's razor is Hickham's dictum, which is informal, but basically says that a patient can have as many diagnoses as they damn well please. And
that's right.
And so
resist the temptation to explain everything through one. That's right.
Yeah, I don't think anyone sets out to have a diagnosis, but it does invite us to think broadly and inclusively about all of the things a person can have, and not just try and nail it down to one thing. So it gets back at this idea of trying to overcome our historical kind of traditional orientation towards reduction. Which PEM defies that.
Yeah, that's good. And that's actually, you're stating that broadly. You're an exceptional educator. You're not saying that to me or at me, but I'm accepting and receiving that education from you. So I thank you for how you deliver that. I need that as well. All right, so I gave you an opportunity to debunk one thing that you wanted to debunk, where people are going to exercise their way out of post-exertional malaise. Todd, before we wrap up, is there any other main approach, hypothesis, philosophy that you would also like to say, no, I can't agree with that. The science does not uphold that. I'd like to also debunk this before we close up.
There's probably plenty of little bits and bobs that I would try and debunk, but we'd be here for 2 hours of continuous diatribe, so nobody wants that. But I would just encourage your listeners to access anything related to trauma-informed care, to try and make sure that skills are sharp in that area. There's a lot of mistrust and anger and sadness over lost function, opportunity, vanishing from society. This is a I think it was Ed Yong, who was a freelance journalist, who said that post exertional malaise is Rob's opportunity, Rob's possibility. And so there's a lot of that. And again, people who are accessing your care, and I'm using that term purposefully, care instead of intervention or assessment, which are very sterile clinical terms. People seeking your care have been through it with other healthcare practitioners. They've been dismissed. They've been lied to. They've frequently in ways that the system has perpetuated violence on these people. So you really would behoove folks who want to be more active in this area and help people in this patient population. And frankly, I think just even as a basic competency in our practice, we really should be much more attuned with how to help people with that trauma, manage it ourselves, and avoid perpetuating some of the violence that the system and some of we participants perpetuate on our patients.
That's excellent. And I think that's true for all of the invisible conditions, isn't it? That there is a degree at which the individual feels that they need to repress their own reporting. No one's listening to them. People are mistrusting them. What's your angle? Why are you malingering? Do you just not want to work? Etc. And all of those things. It doesn't matter. And this can be helpful for some listeners that know functional neurologic disorders well. If you want to stack the education on the dysautonomias and post-exertional malaise to some degree on what you already know about how the healthcare system has let down people with functional neurologic disorders, calling them hysterias, calling them, psychogenic in nature, calling them conversion disorders. All of that is exactly what we're experiencing right now in people with these other less well understood invisible conditions. And so I think that's very helpful to frame that as seek care, demonstrate listening. Now, I guess that brings me to a final question, and I didn't expect to ask this. In functional neurologic disorders, which I know to some degree and have a degree of expertise in, we're refining a capacity to rule things in rather than, it's nothing else, it's got to be that. Todd, leave us with whatever the science is available right now. How do we rule in post-exertional malaise? I've already heard you tell us some about this today. I've been listening to you. And I know it's so multifactorial, it's enormous, and it's five, different degrees of, let's just say 5 dimensions, like you talked about. It's not a 2-dimensional Venn diagram. Tell us about anything that you'd like to help people rule this in. And you can include laboratory values or things that physical therapists feel that are in their scope to test for.
Yeah. So I will go ahead and mention 3 items that a good old-fashioned history can uncover. I'm very low tech.
Mm.
So this is the age of AI, but I'm thinking that we leverage relationships. And so that needs to be the first source of our information. So the things to listen for and ask about. Um, Impaired recovery following an exertion.
Mm.
Are you taking 2 days to a week or longer to recover from simple things like going to the store to go shopping? Are work days resulting in you spending 2 days in bed, for the work week only to get back up and do it again? Um, that's the first piece, delayed recovery. The second piece, I would say, are unusual signs and symptoms during the recovery process.
Okay.
Um, Look, as a guy who needs to hit the gym, I'm going to be tired after I work in the yard or take the dogs for a long walk or something like that. But I am not going to have things like widespread body pains, and I am not
Mm.
going to have brain fog, and I am not going to have sleep impairment. In fact, if anything, I want to take a nap.
Yeah.
So it's unusual symptoms and signs to sort of listen for, and then wanting to know whether exercise makes you feel good.
Mhm.
And people who are deconditioned, at the very least, when the exercise stops, they're happy about that.
Yeah.
And they may even feel a bit of a sense of accomplishment. They may feel helped by that. But if exercise doesn't help, or if they've tried to sort of self-treat by heading out to the garage to dust off those old Tybo DVDs or whatever, and that didn't do anything, that made them feel sick again, then there's another indicator of post-exertional
Wow.
malaise. And then there's a whole host of fancier, lab values and so forth to look at that have been well described in documents like from the U.S. ME/CFS Clinicians Coalition and so forth that I won't go into here. But I would
Yeah.
say just those three top level things to listen for would
Wow.
put you on a very good
That's
track.
beautiful. I'm going to grab that snippet right there and feature that because, Todd, that is a great place to wrap up to give people practical, low tech, reality based, lean in literally to your subjective examination, your interview, and watch for these things. And, Todd, you told us 20 minutes ago, start to change your practice to look for these things in individuals because they can be signs in individuals in conditions that you might not have normally looked for them. So that's great. Rather than trying to paint it all as, well, this person has Parkinson's, so I do look for it, POTS, so I do look for it. Let's look for it and let's rule it in or out by listening for these things because they're approachable, they're reasonable, and they're factual. Todd Davenport, you've exceeded my expectations, sir. Thank you for joining me on Tuesdays with Mike. And this will be a very educational episode. I know it was for me, and it will be for many others. So thank you very much.
Really appreciate it, Mike. Thank you, and thank your listeners. Take care, everybody.
Yeah.